seems as it's getting late and everybody is hungry, and hopefully this will be quick in here. And green is forward, is that right? I have nothing to declare related to this talk, and as you've seen in the title, I used an acronym MVP. If you are not familiar with sports, it's most valuable player. It's a sports term, and just to wake you up, it's NBA final season. So these are great MVP candidates, and the common theme for these players are they are the leaders of their team. They are great scorers, and I'm missing a few of them. Didn't have much space for all of them, but they are definitely scorers and leaders of the team. But what I'm talking about, the similarity of a critical care anesthesiologist and an MVP is, if you are again familiar with basketball, this is Andre Iguodala, was in fact a playoffs MVP a few years ago, I believe. The importance in there is he's one of the best defensive players. So like critical care anesthesiologists, we do the patient's safety, essentially, and we are the main safety advocates. And then he has great assists at critical times. And we assist in everything in the anesthesia side and the critical care side. And multifunctional and versatile player, again, the same thing. We are in at least in 2-3 different places, from ER to the ICU to the OR. And a creative player. Of course, Miguel wants to be Andre Iguodala in there, but I hope this wakes you up a little bit and look at the similarities in the meantime. So he won't get me shortly. Just to review the same things, I don't want to go through everything again, but it's within 10 to 15 minutes, patients need to see a physician and a stroke team. And then within 25 minutes, they need to be in a CAT scan. Within 45 minutes, they need to have the result of the CAT scan. So less than an hour, they need to be a candidate for the TPA. So of course, TPA window is 4.5 hours, 3 to 4.5 hours, but still, you don't want to waste more than an hour in the hospital to give that TPA. So that's what that says. And each 15-minute delay will add a 4% increased disabled patients in there. Just to review that again, what I said was door to TPA time is essentially 60 minutes, and then door to groin puncture time, meaning the patients who will need mechanical thrombectomy goal, is less than 90 minutes. And then your interventionists have about 30 minutes to perfuse. So essentially when the procedure starts. So our role is above and beyond, obviously, it's patient safety. And then the second thing is we also need to watch the clock and help the stroke team in there with the timing. So safety concerns. Of course, 30% of the patients cannot swallow. 50% of the patients cannot be talking to us and tell us what's going on. And then 25% of the patients will have breathing problems, like chain strokes. So, and that chain strokes will mess up the mechanical thrombectomy as well. So it's definitely a big, if I may call it, an art to sedate these patients, or if you will do general anesthesia, then you need to have the responsibility of managing those patients afterwards. So, but above and beyond, airway patency is the first thing, and that's under our responsibility. And whenever it's needed, we need to go for it. And if you look at the AHA, American Heart, American Stroke Guidelines, the same thing again, they bring airway patency up right away, and they suggest to keep the saturation above 94. And then there's another note in there with a lower level, maybe you can say. If your patient is well oxygenated, normoxic, then you don't need to give supplemental oxygen, because hyperoxia may be harmful to these patients. So everything being done, what we do is to save the penumbra tissue, meaning that pink area, if I can go with my mouse, maybe I can. The pink area is the stroke area, which is the dead tissue essentially at this point. But all that green area is the penumbra tissue. It's the salvageable tissue. So the whole aim is to take care of that penumbra area. And we need to realize that there's no autoregulation in that area. So this is a pressure-dependent area if you want to perfuse. And how will we do that? I mean, if you just go through the guidelines, again, American Heart, American Stroke, you realize that there's a permissive hypertension allowed, meaning if your patient is not a TPA candidate, the goals are less than 220, 110. If the patient is a TPA candidate, then the goals will be less than 185, 110. So between the lines, they say MAPS of 130. So these are great numbers that you allow permissive hypertension till recanalization, essentially, and even to some extent after recanalization. And again, do not aggressively lower the blood pressures. Maybe 15% of lowering is safe, again, between the lines. And this is Mr. Clean Studies, one of the sub-publications, essentially. What it shows in here is the immediate baseline systolic blood pressures and its correlation with mortality. And you see that hypotension increases mortality, as well as hypertension, which is lesser of a slope in there. So essentially, the patients will be patients who came with 100 to 150 range at the better outcomes. And if you look at most of our patients, you will see that hypertension is common. Maybe 140 to 160 is a common finding in these patients. So, and when we are reviewing the guidelines, huge respect needs to go to our own society, SNACS guidelines in there, that systolic blood pressure to be maintained between 140 to 180. This is an expert consensus statement, but it's such a valuable statement in there. And then they say it's never to be MAPS, never to be lower than 70 millimeter mercury. So then I will just show you shortly a little bit of our data. This is just our past few years mechanical thrombectomy patients, and I didn't put the standard deviations not to complicate the figures. Just shortly, this is about 130 patients, and this is the thrombectomy period. So this is the MAC or general anesthesia period. So these patients were all got mechanical thrombectomy within 6 hours, like in the old guidelines. And then these patients got successful mechanical thrombectomy, meaning TK2B3. And by looking at these patients' maps during the procedure, and red one shows the bad outcome, modified Rankin 5-6, and blue is the good outcome, which is modified Rankin 0-1-2. You see that there's about 5 to 10 millimeter mercury difference in those maps nearly throughout the thrombectomy time. And look at the same thing. So is this an important difference? It's hard to say, but there is a difference in there. So if you look at the post-thrombectomy 24 hours, and again, the same thing, the patients who came in right time, get the right treatment, and successful treatment with TK2B and 3, and looking at the patients who ended up with good outcome versus bad outcome, there's about 5 millimeter mercury map difference. You will say it's really a small difference, but it's lasting 12 hours plus. So does this have any influence in the outcome? I think being on top of blood pressure is extremely important. We don't know the answers to these yet. And as I promised, I will quickly summarize and finish, and we will have some minutes for questions. So Dr. Koba started and told us that time is brain, and reviewed quickly how we need to manage these patients, and brought the safety concept. And then Dr. Businger talked about mechanical thrombectomy patients to be managed either sedation or general anesthesia. And essentially, the bottom line looks like it's patient safety, and then the procedure's complexity, meaning anesthesiologists and the interventionists will decide on that. And then Dr. Ford brought the importance of stroke units. So maybe not utilizing ICUs, but considering stroke units as well, but definitely not general wards. And then Dr. Villasides talked about a very important topic, perioperative stroke, which is very high mortality and very hard to diagnose. And overall, we showed you some of the guidelines, and American Heart, American Strokes guidelines, and many other European guidelines, but I really need to restate the importance of the SNACS guidelines in here, on this, and the importance of the blood pressure, which there will be more data to follow, and we are the ones to manage those blood pressures. And again, I will just finish up with the same article showing this is just last month, Anesthesia, Analgesia, our journal, and great review articles from the Iowa team, and this is wonderful to see it over there and summarizes most of the things we talked. Thank you very much for your attention, and we are ready for questions. Thank you for your patience.